All right, excellent. I think I will already start with some housekeeping items. Thank you, everybody, for joining today's IARS webinar. It's called Global Critical Care, the Crisis and the Way Forward. And I'm going to run through a couple of slides. This program has not received any commercial support. And in case you missed our annual meeting this year in Seattle, there are on-demand recordings available for purchase. So please check out the website link below. And then the next conference is going to be in Hawaii. The submission deadline is Sunday, December 8th. And Hawaii is always a fantastic place to be for IARS, so I will certainly be there. Okay, we will be available for questions, comments, and continuing this discussion in our IARS member community, and you can find it at www.docmatter.com/IARS. And there's also a QR code for you to use. Then more upcoming, very interesting webinars. There is one on December 10th, again, the same time. Interesting articles you might have missed from our subspecialty ICU literature. And then January 14th, opioid use disorder and the anesthesiologist, what you need to know to impact this escalating crisis. And I believe with that, we are going to have our first speaker today. I will introduce Dr. Crawford, who is an intensivist and anesthesiologist at Stanford. She also holds a master's in global health science, founded the Division of Global Health Equity within the Department of Anesthesiology, Perioperative and Pain Medicine at Stanford, and is currently the Director of Global Engagement Strategy. Besides serving on and chairing multiple committees, she also serves as an advisor to several international organizations, such as the WHO and the Lancet Commission. And thank you, Dr. Crawford, for jumping in on short notice for Dr. Odinkemelu. So thank you. I'm going to stop sharing and hand over to you.
Wonderful. Thank you, Dr. Moll, and thank you everyone for attending this webinar. As Dr. Vanessa alluded, our colleague Didi is unfortunately delayed from a flight. So I am going to do my best to represent her topic well. We are talking about global critical care and want to set the setting for what that means and why it's relevant to all of us. So we're going to talk about the global burden of critical illness. And again, special thanks to Dr. Didi for her slides. So there are three objectives for this portion of the discussion. We want to really challenge the definition of critical care and critical illness. We want to provide a brief overview of critical care as an item on the global health agenda. And then we want to work to characterize the global burden of critical illness. As many of you know, critical care and critical illness, well, critical illness has always been around, but critical care really began to evolve, some would argue, very early on with Florence Nightingale, realizing that she needed to put injured soldiers closer to the nurses' station so that she and others could monitor them more closely. And then in the 1950s, with the polio epidemic and the advent of the iron lung, it became pretty clear that some critically ill patients needed specialized equipment and especially trained providers in order to optimize their outcomes. But it really wasn't until the mid-1970s that we started to have organization around critical care as a professional society. So the first issue ever of Critical Care Medicine actually was in 1975, and intensive care medicine followed thereafter. It was shortly around the same time. And then I think another big development in the way we think about critical illness and critical care is really talking about the critical care continuum. And there was a great statement put out by Jean-Louis Vincent that talks about critical illness not as just the illness that occurs in an ICU or the care that occurs in an ICU, but also across the entire care continuum, recognizing that the way we treat patients prior to and after ICU is just as important factor in impacting their outcomes. So again, another big challenge of what we think of as critical illness and critical care. This study out of Sweden found that 90% of critically ill patients are actually found outside of intensive care units. I think this is incredibly important for us to reframe the way we think about critical conditions and critical illness, and therefore the way we treat that. Sweden is a high-income country with lots of resources, but that 90% of critically ill patients being found outside of ICUs is as true in Sweden as it is in Malawi, as it is in Sri Lanka. So this is true across resource settings. So you can answer in the chat, or if you've worked in a resource-constrained setting. So I think a lot of us have, but some of us may not have. But I'm going to go ahead and jump forward to the answer and just suggest that really all of us should have said yes to this. In the pandemic, Los Angeles ran out of oxygen. All of us are currently under supply chain disruption with our intravenous fluids and dialysis fluids because of the hurricane on the East Coast. Again, oxygen was a big deal during the pandemic. And just to stress that we may think of global critical care or global health as something that happens in other places, but even within our rural settings, and especially amongst like our Native American neighbors, some of the health outcomes are equivalent to those that could be seen in for example, Haiti. So it really does apply to us and our neighbors. Similarly, global includes local in that our populations are increasingly diverse. We have large percentages of immigrant populations and a very, very diverse set of providers as well. So things that are relevant to different cultures and populations certainly come into play in our practices, usually daily. So the US population, I said, is increasingly diverse. So it's significantly more diverse racially and ethnically than it was in 1900. Contemporary immigrants from Latin America and Asia are joining African Americans and American Indians who have always been a part of the US population. The rising racial and ethnic diversity in the US is already most apparent amongst the youngest Americans. And the chance that two people chosen at random are from a different race or ethnicity groups has increased even since 2010. So I think it's really important for us to optimize our patient outcomes when we are globally conscious and culturally aware. The other challenge is thinking about critical illness. We often think about the ICU, as I mentioned, but we also think about critical illness as an independent diagnosis. So we may think of septic shock, we may think of ARDS, for example, but critical illness and therefore critical care can really arise in any patient population. So it could be pediatric patients, elderly population, obviously obstetric or maternal conditions, and it might be related to other conditions such as trauma that might need a surgical intervention. So critical illness is certainly cross-cutting, affecting multiple different types of patients arising from multiple different diagnoses. So we need to really understand that critical illness is wherever patients are. It doesn't necessarily occur across specialties or diagnoses. It's really a patient-centered problem. So critical care has long been neglected, unfortunately, and I think that is because we often conflate critical care with ICU level care, which is very expensive and very advanced. However, with the recent pandemic, I think that the opportunity window to realize that critical illness can affect any setting, whether it's high resourced or resource constrained. And so shortly after the pandemic in May of 2023 at the World Health Assembly, the first ever mention of critical care was made as a global health priority. So in 2023, there was a passage of a resolution called the ECO resolution, which stands for Emergency, Critical, and Operative Care. This resolution was essentially the member states vowing to strengthen their healthcare centers to offer better emergency, critical, and operative care. And again, this was significant because it's an opportunity window for all of us involved in critical care to really advocate for improvements in our healthcare systems to improve patient outcomes. The ECO resolution was again mentioned this year at the World Health Assembly with further discussion about ways to implement health system strengthening for the ECO components. Estimating the burden of critical illness across the globe is incredibly difficult. The true burden is not only the amount of critical illness, but also our capacity to treat the critically ill. It's imprecise because it's not listed under one diagnosis or disease state. As I mentioned, it stems from multiple different disease states and can occur in multiple different locations and involves all types of patients. It's certainly not completely aligned with the number of admissions to the intensive care unit because in a lot of places they don't have intensive care units. So ICU admissions may not be the best surrogate for the number of critically ill patients. Similarly, some try to estimate the burden of critical illness using ICU resource utilization numbers. However, I think most of us recognize that the utilization of resources in the United States, for example, is incredibly high, whereas in other places it's a lot less and probably a little bit more effective use of resources. So that doesn't necessarily correlate with the burden of illness. And then as we pointed out at the beginning of this talk, even the critically ill patients may or may not be recognized. If 90% of critically ill patients are found on the wards and not within intensive care units, then we may be underestimating. The unfortunate fact is, as with many other burdens, those with resource constraints, especially those in low and middle income countries, have a higher share of disease burden in general and decreased life expectancy. So again, we can try to get at the entire burden by looking at some other types of critical diseases or conditions. So we can look at sepsis, and the numbers are really high: maternal mortality, perioperative critical illness, and critical illness in general. However, these numbers are very high and additive. They may actually add up to a number that is greater than the total number of deaths per annum. But all of this to say that the number of critical illness patients is quite high. I think another challenge is in the way that we think about critical illness is to recognize that post-operative care is also critical care. Although over time we've done a remarkable job about making intraoperative anesthesia safer and safer and safer, our patients still continue to die postoperatively. So it's really important to recognize that critical conditions, critical illness occur not just in the ICU. And if we are great perioperative physicians, then we need to also remember that our postoperative patients are at very high risk. So reducing intraoperative mortality by roughly a factor of 1,000 was a remarkable achievement, says Dr. Dan Sessler, but postoperative mortality remains stubbornly high and hasn't much decreased in recent decades. In fact, it remains the anesthesiologist's greatest challenge. So measuring the burden is challenging, and in summary, the burden is often outside of the ICU, and that burden may be neglected. There's no single diagnostic test or diagnosis. It often, critical illness is quite quick, can be short-term, and with a high mortality. And it's often conflated with other specialties or other resources used within the healthcare system. Some barriers are certainly resources such as equipment and infrastructure, training, context-specific guidelines, and unified definition are some of the things that we need to work on. And some of the ways forward is to improve our health systems and quality improvement. That's certainly the ECO resolution is trying to get at that. Making sure we have a consensus definition so we can better define the burden. increasing access and quality of training, and ensuring that any of our critical care programs are built upon a solid foundation of critical care, which is something we'll talk about in the next discussion. So with that, thank you. Again, thanks to Dr. Didi for putting those slides together. My email address is here. And I would like to thank our moderator, Dr. Vanessa Moll, and introduce her as a very experienced global health professional, also an anesthesiologist and intensivist at the University of Minnesota in Minneapolis. Dr. Vanessa has many, many skills, including cardiothoracic. She's a very successful researcher. And I'm so happy to have her as a colleague in global health initiatives. So with that, I'll turn it over to Vanessa. Thank you.
Thank you so much, Dr. Anna. And it's incredible how you just took that presentation and just breezed through it. So thank you so much for this great talk. I will be talking about essential emergency and critical care, the fundamentals everywhere and every time. I have no relevant disclosures to this lecture, and I will be jumping right into some cases. So our first case is a pregnant mother at 40 weeks. She has a seizure at home and is brought in by her relatives to the hospital. She is unconscious. At the hospital, she is diagnosed with eclampsia. And then she undergoes an emergency C-section and a healthy baby is delivered. Postoperatively, she is placed on anti-seizure medication, but she dies on the floor overnight. Our second case is a young motorcycle driver. He got himself into a road traffic accident and arrives at the hospital covered in blood. He's diagnosed as a polytrauma. He is sent to the CT and immediately thereafter to surgery, which he survives well. He goes to the floor after, and the two first postoperative days were very uneventful on the floor. However, he also dies on the floor on the third night. And then we have a Pete's case. We have a 2-year-old boy. He has an increasing difficulty of breathing. His parents bring him to the hospital, and upon arrival, he is very short of breath. The clinicians get him to a chest x-ray, and he is then diagnosed with pneumonia. He's prescribed antibiotics and transferred to the floor. He also dies on the floor overnight. So why did our patients die? Was it a lack of OB care, of trauma care, or PEDS care? Or was it a lack of critical care, a lack of ABC care, airway, breathing, circulation care? Was it a lack of this foundational care for critical illness that Dr. Anna already talked about? A lack of EECC, essential emergency and critical care. Critical illness, again, is a state of ill health with vital organ dysfunction, a high risk of imminent death if care is not provided, but it also has the potential for reversibility. Critical care is then the care for critical illness. And successful critical care has a time component, a critical window of opportunity to reverse a certain condition. Recognizing the signs of deterioration are crucial for optimizing care and optimizing patient outcomes. Take sepsis, for example. Early recognition and treatment with antibiotics and fluids within the first golden hour of sepsis can significantly reduce mortality. Critical illness happens everywhere, and as we learned from Dr. Anna, most critically ill patients are actually on the floor or on the ward. These patients need to receive this foundational early critical care to reverse their critical illness trajectory. So critical care has different levels of complexity. The most elaborate and advanced level we provide in the ICU. So think mechanical ventilation, think ECMO or CRRT, kidney replacement therapy. Intermediate critical care might provide vasopressor therapy, CPAP, and then EECC, essential emergency and critical care, which I call the foundational critical care. is the care that happens everywhere in the ED, the OR, the floor, the ICUs. And as you can see on the left-hand side, the foundational critical care, oxygen, fluids, triaging, and monitoring is really not that cost intensive. But as the higher you get in the complexity of care, the more cost intensive critical care becomes. Essential emergency and critical care is a foundational, universally applicable form of critical care. And EECC is based really on 3 principles: prioritizing those with the most urgent clinical need, providing life-saving treatments to support and stabilize our patients, and focusing on first-tier effective and low-cost care. And again, examples would be fluids, oxygen, antibiotics. EECC is designed to provide a foundational level of care that is accessible and applicable to all patients, regardless of location, economic status, or healthcare infrastructure. It targets the minimum interventions necessary to stabilize critically ill patients, making it feasible in both high-income and low-income countries. There has been a Delphi consensus around EECC. And this process engaged 269 clinical experts from a diverse range of acute care fields, including emergency medicine, intensive care, critical care, internal medicine, surgery, pediatrics, obstetrics. And these clinicians came from various healthcare settings and income levels, low, middle, high income countries, low and high resource settings, ensuring that perspectives of all were heard. And through these iterative rounds of surveys, discussions, and feedback, clinical processes were decided upon, as well as hospital readiness requirements. So the ECC concept is really rather easy. You identify the critically ill patient. The patient receives foundational critical care. So that means the patient will get effective coverage of foundational critical care, EECC, after the patient is stabilized and the patient survives. And within the identification and the provision of treatment, we have the clinical processes and we have the hospital readiness. The clinical processes include identifying critical illness. So that would be monitoring vital signs like blood pressure, pulse rate, temperature, respiration rate, providing timely care, prioritizing patients with the most urgent clinical needs and providing the care quickly, stabilizing vital organs, for example, providing treatments to support and stabilize organ failure. So oxygen therapy, fluids, or even just maintaining an open airway. And then communicating effectively and documenting care. So handover processes, for example, are talked about in the EECC management. But things like blood transfusion or higher levels of care like CPAP, vasopressors would not be included. EECC is really based on standard practices. On the left-hand side here, you see the vital signs-derived therapy protocol. And in this protocol, vital signs are classified either as normal, which is in green, abnormal, yellow, or danger, which is red. A danger sign would prompt an immediate treatment. To enable quick care in the absence of physicians, this protocol was designed to include actions that could be task shifted to our nursing colleagues, for example. So, for example, if the danger sign was a low blood pressure, nursing would be tasked to provide IV fluids to address low blood pressure. So really standard practices. In the hospital readiness, the group identified 66 hospital readiness requirements, such as basic equipment, drugs, consumables, guidelines, and infrastructure that are necessary to effectively deliver EECC, this foundational critical care. And this is really the minimum standard of care that any critically ill patient should receive, regardless of where the patient is. There is a large unmet need for EECC. In Kenya, pre-COVID, for example, only 58% of beds actually had an O2 supply. In Malawi, 90% of hypoxic patients do not receive oxygen because there is no oxygen available. And in Tanzanian wards on the floor, only 56% of resources required for EECC are ready for use. That actually means they might be available, but they are just not in a place to be used. In Africa, C-section mortality is still 50 times higher. Ped surgery mortality is 11 times higher. And then in Sweden, 30% of critically ill do not receive this foundational critical care. So foundational critical care, irrespective of being in a high resource or low resource setting, is not provided to our patients, to the majority, to all of our patients. EECC is cheap, cost-effective, and feasible. Looking at some studies, this foundational critical care costs about $17 per day. It is $14 per healthy life year saved, and this equals malaria treatment and emergency OB care. And it's more cost-effective than our ICU care, which is very expensive. A study has also shown that hospitals have actually more than 80% of the resources required for EECC already. They just have to be put in the right place. For this foundational critical care to be working, we have to train our workforce up. And we also have to procure and maintain our equipment. So why should we implement foundational critical care? Why should we implement EECC? We need to increase the impact of our ICUs and decrease the need of ICU admissions. So by providing foundational critical care, we change the trajectory of critical illness so that patients do not need ICU level care. We need to increase the impact of scaling up oxygen. Dr. Crawford talked about the oxygen shortage. We need to build up our pandemic and emergency preparedness. And mind you, even after COVID, the COVID pandemic, we are not any more prepared after than we were before, which is extremely scary. And then as a vital part of universal healthcare coverage, health system strengthening and the quality of care needs to be strengthened. And we need to reduce perioperative mortality rates, because perioperative mortality, again, Dr. Crawford mentioned that it's the third leading cause of death. So we really need to implement foundational critical care. Here I'm showing you two studies that are currently ongoing. The first one is EECC in Tanzania, and it's a sponsored study by the government of Tanzania, UNICEF, and the university in Dar. And in this study, the Tanzanian government is supporting EECC in primary healthcare clinics in mainland Tanzania. The other study ongoing is the IARS trial, which is a quantitative observational study of critical illness across Africa. And here, the researchers are also looking at the relationship between EECC provision and mortality, and the availability of the resources in the hospitals for this foundational critical care. Back to our first cases that we started with. Our pregnant mother, the motorcycle driver, and the 2-year-old. What is really the vision? Well, the vision would be that all critically ill patients receive foundational critical care everywhere in the world and every time. We triage patients, we rapidly identify them as critically ill, and they receive the foundational care. They receive oropharyngeal airways, oxygen, fluids, anti-seizure medications, repeated ABCs, close observations. We are titrating care up and down. They all receive safe and good quality foundational critical care, and they survive. And that concludes my talk. A couple of take-home messages. Foundational critical care is vital. It's neglected in all parts of healthcare systems, including high income, low income, and it's really necessary to increase our emergency preparedness and response. Foundational critical care can be effective and have a population impact. And foundation critical care, importantly, is for all clinicians. This is also a call to join the network. There is a QR code on the left, and the link to the website is also shown. So please check it out and join the team and join our efforts. Thank you very much.
Thank you so much, Vanessa. So I'm gonna take us home with the third talk. But just want to again thank you for talking about EECC. I think it's so incredibly important and really is that foundation upon which all other critical care should be built. I think for some people it might be especially if you practice in a really high resource setting, it might not be as obvious, but that critical care is not being delivered, and I think that's where the problem is. Okay, let me go back to my slides. Just one second. Okay, let's see if this works. Okay, can you see my slides, Vanessa?
Yes.
Okay, wonderful.
Thank
So I'm
you.
going to go ahead and get started and talk about training the global workforce for critical care. EECC is certainly part of what I'll talk about, but in general, just talk about how do we, where are our barriers in the workforce and how do we get people trained up to more rapidly identify patients when they're critically ill and respond within that reversibility window. So I'm going to talk a little bit about the landscape, the challenges, and then talk about a few strategies that we have used over the years to address workforce training. So I think many of you probably know that the World Health Organization describes a healthcare system with 6 building blocks, including governance, infrastructure, the workforce, which we're talking about today, service delivery, information management, and financing. I would actually, and often do, argue that service delivery should actually be the output. That should be the product where we're taking care of our patients. So within these health systems and health agendas in 2015, I think many of us know, because we're anesthesiologists, that was really when surgery was moved up the list as a priority within the global health agenda, and that's when we really established surgery as an indivisible, indispensable part of healthcare. And that launched an implementation across countries to really develop their NSOAPs, or National Surgical Obstetric and Anesthesia Plans. And as I mentioned in the first talk in May of 2023, on the heels of the pandemic, again, one of our core subspecialties was again ascendant upon the global health agenda, and that was critical care. So with the ECO resolution, meaning emergency, critical, and operative care, countries across the globe are now vowed to strengthen these components of the healthcare system in order to improve patient outcomes. So you can see that workforce is one of the main domains of the NSOAP programs. And with that, we have worked over the years to track and survey the number of anesthesia providers across different countries. This work was largely led by the World Federation of Societies of Anesthesiologists. So in 2015 to 2016, you can see the data on the left in a color code map. And this data was recently updated just in 2023. And so we can see that although we've had some improvement in the workforce around anesthesia, or I like to say perioperative care as an intensivist, we still have large gaps that are not meeting the needs of the number of surgeries and interventions we have, and also our patient needs. So specifically, the recent workforce update has highlighted that although we've had an increase in the number of physicians, we're still less than 5 per 100,000 for at least 75 countries that responded to the survey. And the total provider density, that includes the physicians and non-physicians, is still less than 5 for at least 64 countries, excuse me. The recommended number by the WFSA is at least 5 or greater providers per 100,000. So these are the less than 5 numbers are significant. Africa has the fewest number of physicians. Asia has the fewest number of non-physicians, whereas Europe has the highest numbers of all trained providers overall. So we're headed in the right direction, but still have a lot of gaps. So one of the big challenges is that without fellowship trained or super specialist or any kind of specialty training in critical care, the large majority of care for critically ill has fallen into the laps of anesthesiologists, yet we still have too few anesthesiologists in practice. Additionally, without access to formalized critical care training programs, the teachers that are teaching these anesthesiologists may be propagating some of the limitations in their own practice without advancing the care of the critically ill. So it brings a challenge of how do we actually increase the number of specialty trained critical care physicians or providers while we still need to decrease or close the gap on anesthesiologists in general. Many of us feel that the balance between demand and supply is in jeopardy, where we have an aging population, a growing population. We certainly have an increase in our non-communicable diseases, such as cardiovascular and cerebrovascular diseases, obesity, diabetes, etc. We have great familiarity, probably too great familiarity now with pandemics and epidemics. We are seeing more natural disasters. We're having conflicts across the globe. And just the simple ambitions of having universal health coverage, all of those things add to the demand side of this balance. Unfortunately, we have an aging population. That also means we have a retiring workforce. We have, with the increase in demand, we have increase in burnout. That's especially true after a pandemic, or if any of you have worked in a conflict or natural disaster, it's quite taxing. We have increased turnover in providers, decreased recruitment, and then we have also some migration occurring. So something we need to keep in our minds as we work to not only provide care to our patients, but recruit and train colleagues into our specialty. The World Bank and the World Health Organization did an estimate on human resources for health that essentially boils down to a shortage of 18 million health workers that are going to be needed. So we have an underinvestment in education and training of health workers, certainly, but we also have a mismatch, meaning that the way we're training and what we're training them for does not necessarily match what the health systems and the populations need. So the mere availability of healthcare workers is not sufficient. Only when we are equitably distributed, accessible to the population, and possess the required competencies, and are also motivated and empowered to deliver the quality of care that is needed. That's when we have an appropriate and acceptable number of healthcare providers. This Lancet Commission did a really great job highlighting that it's not just about access to healthcare, it's also about the quality of healthcare that is delivered. And they estimated, I believe it was like 5 million more lives could be saved each year if we improved the quality of healthcare systems. For those of us working in high income settings, we know that our patients will go to the larger tertiary or academic centers because they think that the care is better. And they'll do that even though they may be just a mile from another hospital. So it's really that trust that you're going to receive the quality of care that you deserve. I underestimated it's 8 million lives could be saved each year. One other striking statement in this Lancet Commission was the care that people receive is often inadequate and poor quality. And this is common across conditions and countries. Again, the most vulnerable populations faring the worst. They also said that your health system will know when the health system has good quality of care when its leaders stop going to other countries for their personal health care. Some may be wondering why global critical care and these issues that happen in other countries are important to anesthesiologists. And I think I mentioned this and just want to reiterate that anesthesiologists is synonymous with critical care across the globe. Here in the United States, anesthesiologists are only about 5% of ICU doctors, but it is the opposite percentage across most of the globe. So we really need to work as anesthesiologists to do a better job as perioperative physicians. That includes critical care, whether we deliver that care ourselves personally or whether we advocate for our specialty. I think it's really incredibly important. The Society of Critical Care Anesthesiologists released this fellowship trend among trainees, which shows a downward trend in the curve, which really is highlighting more accurately the expansion of programs, meaning we have more critical care training programs, but the demand from trainees has not kept up with that. So we need more, but they're not actually applying. So let's dive in a little bit into training and some of the strategies and considerations around training the workforce. We've mentioned briefly, and there's a great question in the Q&A that I'm hoping to get to right after this about the recognizing the patients when they're critically ill, responding quickly, and actually rescuing them, not just doing one thing, but rescuing them from that critical condition or critical illness. And catching them within that reversibility window. So it's not only just treating them in that first stage, but rescuing them and reversing that course. And this is really what we're talking about when there's a mismatch in education strategies in the health systems, because we may need ICUs, but also we certainly need to have providers available on the wards, in the emergency departments, in our post anesthesia care units that can all recognize this critical illness quickly and respond in a timely fashion. So recognizing the care continuum, we have the recognize, respond, rescue, reverse. And a lot of this, I think about a lot with training because there is just a wealth of information within the resuscitation and triage part of the continuum. It's the sexy part of caring for critically ill patients. This is where you might do a needle thoracostomy or an airway, or start a central line or arterial line, etc. But the thing that is lacking is once a lot of these algorithms will end and then elevate to a higher level of care. And so for a lot of situations, whether it's a rural part of a high income country, so part of that urban rural divide, or whether it's in a country that has fewer resources because of the economics of that situation, there's a lot less emphasis on building up ICU training so that if a patient is fortunate enough to be transferred to an intensive care unit, their mortality rates are still unacceptably high because no one really knows how to get them back out of the ICU safely. Another deficit in availability of training is around that foundational or fundamentals level, which we talked about EECC. And then similarly, there are some materials and luckily increasing number of training materials for if the patient survives the intensive care unit, how to take care of them in the post-ICU. One of the key points of training is knowing your learners and at what stage they are. This slide really just breaks down kind of the graduation across our careers, where we are and what we need for learning and training at different points in our career. So medical students, nursing students, students of any kind are going to be on the bottom left, where they're probably looking more for the core curricula and classroom learning, more didactic style learning. And then we start to learn how to use our newly gained knowledge in a practical sense. So competencies, milestones may be more of a way to focus on how to advance our practical learning. Early independence of bedside providers. We look towards like different forms of scholarship and accreditation. And then if you've been practicing for a while, then you're continuously looking at ways to continue your professional development and maybe even looking for leadership opportunities. So with that, you need to consider different ways to train for a global audience, which is what we're talking about when we're talking about global critical care. So when you're talking about content design, you want to really, I always say, curation over creation. There's so many amazing materials out there. There's no reason to recreate the wheel. So you can look and use your understanding and experience to curate high yield, high quality resources for your learners. You want to make them modular. You want to consider if you're doing a live in-person synchronous learning like we are today on a webinar, or whether that learner is going to be studying independently, such as an asynchronous, in-person versus remote. Timely updates. If you build something, you need to make sure that you keep it up to date. When we're considering building things for practical trainings or application of knowledge, we can use things like simulation, case-based discussions, milestones. Serious games are becoming more and more popular and have proven to be very engaging for the learners. And these are just gamification of concepts and applying them to clinical scenarios. Skill proficiency, we've all done skill stations. How do you open an airway? How do you use a bag mask for manual ventilation, et cetera? So building different ways of skill proficiency, and then really thinking about the training outcomes. How do you change a provider's practice to optimize patient outcomes? It's what we're really, really looking for is improved patient outcomes. So when you're developing your content and your practical trainings and your skill proficiency, you should really have the training outcomes or the patient outcomes in mind. Just to give a little bit of an example, we've talked a little bit about EECC. We have an international working group that has developed a course on EECC. It's available on the Global Anesthesia and Critical Care Learning Resource Center in the top left with that QR code. It's also available on the UN Global Surgery Learning Hub. Both places have CME, so if you have colleagues or you yourself would like to get CME on EECC, you're welcome to do that. On the right, you can see the menu of the different modules within EECC. So this is talking about global access, it's free, and then it's a modular design. So some of the things within the course itself that makes it easier for the learners and hopefully expands impact is that you have downloadable materials so that learners can either view it in a webinar format synchronously or they can download things later. This is also great for trainers in that they can download these materials and use the materials to train others within their setting. I mentioned already that it's modular. This one also has a very interactive discussion forum so that learners can type questions into the discussion forum and then have all of their other learners from across the globe help answer. So it really gives unique crowdsourced solutions, especially when you have variably resourced settings. You want to keep it interactive. Some people like slides and didactics. Other people like videos or they like different exercises. And that's where gamification and some of these other things come in. When you want to apply the knowledge that you've gained to practical situations, case-based learning is a great way to do it. Simulation, these are some examples of our simulations. Dr. Moll mentioned vital signs directed therapy. I cannot emphasize how effective this was when I was teaching some colleagues, nurse colleagues in Rwanda, because not only does it tell them when the vital sign is abnormal, but it tells them what is that first step that you take to manage the patient. Because working with people across the globe, you start to realize that people may do the wrong thing, people may not do anything, people may turn away from the situation for fear that they're going to do the wrong thing. So having that first step intervention is really, really helpful. Entrustable professional activities is another way to do skill proficiency training where you have a step-by-step explanation of how to, for example, place a peripheral IV. There's lots of different ways to translate knowledge into practice. EECC has also developed a hospital readiness assessment. So this is really great if you wanted to roll out this course, for example, in a certain setting, to know whether the equipment is there for implementation. This is an example of a training menu that we have created, and this allows for flexibility. So if you have one certain setting, for example, that wants to implement a training, EECC or some other type of training, this type of menu can give you an idea of the content, the practical skills, the assessments. It could be a 1-day course or a 3-day course, the different types of learners that may be involved. And so you can use a menu like this to design the in-person course or virtual course. But additionally, when you go through these things with the end user, it's also a good way to do a needs assessment. So that's a lot about the content and development of strategies around these courses. But I think one of the most important thing is that it's scalable and that you have stakeholder buy-in. Most of these things are much, much more effective when they're led locally, and the need has been assessed by the bedside provider. So building champions and trainers is also a great way to expand your impact. So training in the global workforce, make sure you prioritize the patients, collaborate with local stakeholders, and make sure that it is going to be effective within their specific resource context. Focus on the learner's needs, and then make sure you can scale and adapt. And with that, thank you.
Thank you, Dr. Anna. This was a fantastic, very insightful lecture. And do we have any questions?
I did have a couple. Yeah, I wanted to bring one up specifically because I thought it was really great. This is from Lawrence Lee, who states that in my experience, the common factor is that the acute stage of treatment of critically ill patient is often treated as if it has peaked and is on the wane at the time of treatment. My definition of critically ill patient includes the presence of severe inflammatory response, traumatic, obstetric, infectious, etc., and that continues to mount for the next 72 hours. So patients are often under the wrong level of intensity when they reach their maximal level of stress. This is such a great point. In conjunction with that, they are subjected to the cascade of being taken care of by the most junior staff, working their way up through senior residents and fellows, and finally to the consultant, but it's 24 hours later. In terms of ordering antibiotics and being sent to the floor, the urgency can be lacking and many hours can pass before IV infusion is actually given. I didn't see much change for 30 plus years of my career, so we need a greater sense of urgency, less complacency, and that should be the basic requirement. So I could not agree more. And I think that continuum of care is something I think a lot about. And I think to be quite honest, when I was first introduced to EECC, I just thought, this is so obvious. Everybody's checking vital signs. Like, why is this happening? And I think that's one point to realize, is that it's not happening. And that's why we have people that die in the wards or die in the recovery rooms, or may not make it to the right resources in time when they're coming from the emergency department. And so that recognition, failed recognition response in that rescue window, I think is really what Dr. Lee is talking about. So I think that's a really important thing, because it's not like you do one thing and the patient's automatically better, right? You have to really continuously reassess. So thank you so much for that comment. And Vanessa, what did you think about that comment?
Yeah, no, I absolutely agree with the comment, and I just want to make sure that the listeners will know that this happens in high resourced settings as well as in low resource settings. So this is a common occurrence, I think, at the place where I work, probably also where you work, Anna, that patients deteriorate on the ward and danger signs are missed. And that's also why we still have a high perioperative mortality. Our patients do not die in the operating rooms anymore. They die on the floor. So clearly we have not addressed this foundational critical care, and we have not addressed the urgency that these patients deserve to be taken care of, and to reevaluate them in a timely manner.
Certainly. Yeah. In some of our other discussions, I've used 2 clinical vignettes. One is a woman in extremis who presented in Lesotho with just grossly deranged vital signs. And the other woman presented to somewhere in San Francisco Bay Area in California with very highly resourced setting. And the woman in California was actually sent to the intensive care unit. But unfortunately, she had altered mental status. She was kind of moaning. The nurses had a difficult time getting a central line or an IV at all. So she had an intraosseous line placed. But because she was moaning, they considered her responsive. And even though they struggled for many, many hours to get a pulse oximeter reading or an accurate blood pressure, she had no arterial line, et cetera. Her care was never escalated in that the ICU doctor was never notified that she had been admitted. And then the woman in Lesotho was assessed with those grossly abnormal vital signs, sent back to the line or the queue to wait for a doctor, even though she was, really, really critically ill, and was lucky enough to have an ICU doctor walk by and notice her just by looking at her, how ill she was. And the moral of the story is the woman in Lesotho was resuscitated, diagnosed, treated, and survived. And the woman in this very highly resourced setting in the United States actually wasn't seen by a physician until probably 10 or 12 hours later and was unrecoverable. So I think it's really important for us to realize that this is something for lots of different resourced settings. So we have a couple questions that spurred, so thank you all. Can you, Dr. Moll, it says, how can we address the lack of recognition of critical illness in high-income countries versus low-income countries? The lack of recognition of
the lack of recognition. Yeah, I think we can very likely address it in a similar way. I think if we train people, easy protocols like the vital sign derived therapy, for example, if we train our nurses, our trainees, our advanced practice providers, our clinicians in triaging patients and actually recognizing danger signs that we define maybe in an easy way of traffic lights, we might be able to address this lack of recognition, which is also then a lack of urgency, because if you don't recognize something, then obviously there is no urgency for you to do so. But yeah, I think this is a great question. Thank you, Dr. Lupe.
Yeah, I would just add that there's a lot of, I think, etiologies for the lack of recognition. It might be insufficient or inadequate staffing numbers. It might be inadequate training at baseline. It might also be a lack of infrastructure or equipment. So, some studies in very low resource settings suggest that there either is a lack of equipment or the equipment is there, but because it's so scarce, it's actually locked in the matron's closet and inaccessible to the bedside. So there's many of those types of things. And I think when you have a more highly resourced setting, this lack of recognition can be for all those same factors, but also can be due to complacency. If the patient's not in ICU, then they're not critically ill. So it's really about reiterating and retraining and continuing professional development training to recognize critical illness. So I think that might be helpful in higher income countries. So Dr. Lena Dolman has said, wonderful lecture and resources. I've seen the others help with education. Oh, she's helping with master's students in Uganda and would love to send them resources you have presented. I'm sure that IARS will have some of these resources compiled. This webinar will be recorded and shared. Additionally, for the EECC course specifically, it is available on the Learning Resource Center as well as the UN Surgery Global Surgery Hub. Okay, so another comment. As it was clearly stated in the webinar, one way to forward better quality of care in critically ill patients is to increase professionals. What is being done in regards to this or any plans globally, especially in Africa? lots and lots and lots, I would say. So in Africa specifically, there are lots of opportunities to advance anesthesia and critical care. There's the West Africa College of Surgeons, and there's Conexa and COSEXA. Those professional societies are continuing to expand their teachings and resources available. Additionally, we are seeing some increase in the number of fellowship training programs for physicians. I know Ethiopia, South Africa has several. I think Ethiopia has a training program or two now. Rwanda is trying to develop critical care fellowship training programs.
I believe Kenya is
Kenya,
developing an ICU fellowship program.
Kenya has one that's started, stopped, and I think has restarted. Ghana, I believe, is also trying. So there certainly has been an increase in the number of programs that are being developed, but still a gross lack of resource. But I think webinars like this one, the World Federation of Societies of Anesthesiologists is also doing a critical care webinar. So just keep an eye out, and I think continue to expand and nurture your networks of like-minded professionals is my best advice.
And I believe WFSA also offers fellowships in critical care. They have fellowships in peds, regional anesthesia, and I believe there might be some in critical care as well that is worth checking into. They're usually 6-month fellowships in various countries.
Karthik Raghunathan says, what are the most frustrating and most rewarding things in your work? I'm going to let you take that, Dr.
I think the most rewarding things are to develop friendships and develop partners abroad. I really enjoy that. I enjoy teaching abroad, but I more so enjoy building up these fantastic partnerships and these amazing friendships and working together in a collaborative way to further anesthesiology and critical care globally. I think that is extremely rewarding. Frustrating. I think frustrating to me is I'm not a very patient person, so the level of or the speed with which things progress is oftentimes very slow at a snail's pace. But I think that's probably anywhere. But that's what is frustrating to me. But the rewards by far outweigh for me. Anna, what do you think?
Same. I thank you for the question. I think it's really great to always periodically reflect back on where you are and what you're doing and why. And I would just echo what Dr. Vanessa said in that was fortunate enough to travel when I was an intern and have been doing global health essentially ever since. So I'm about 16 years into my global health career. And I absolutely love building friendships and partnerships around the globe. And because I'm at Stanford University in California, a very, very highly resourced setting, I like to imagine that I'm kind of stealing from the rich to give to those that don't have the same opportunities that I do. So I really enjoy finding ways to leverage the high resource setting with building opportunities for others. And so a lot of that is with education and training, mentorship, research, getting people opportunities to present or publish makes me very, very happy. And yeah, just having a WhatsApp thread with thousands and thousands of friends all over the globe just really makes my heart sing. Those are certainly the rewards and drive my passion for working with others. The frustrations are Many, but anytime I get frustrated, I like to reframe it as an opportunity to really get tenacious and creative and innovative in finding solutions. So I think one of the greatest barriers in making healthcare equitable and of high quality for everyone across the globe is economic and governance. So those are the two things that are hard realities. You know, some places there just simply are not resources available, or the resources are available, but they're not allocated by the government or governance in a way that can be effective for use at the bedside for patients. And so getting into advocacy and those types of things is a very unique challenge. So can it be frustrating? Yeah, but frustration only lasts for a minute because you need to reframe that as motivation. So I try to flip it on its head a bit. Something that has been easier as I get older. When I was younger, I think I would probably just get frustrated, but now I've learned how to harness that into opportunity.
Excellent. Great answer, Anna. Thank you. Mulemwa Lubinda. In our setting, the sickest patients are often treated by the least experienced doctors and no mandatory CMEs and BLS, basic life support, or advanced cardiac life support. Poor enforcement. How can we collaborate to generate data to highlight and address these critical gaps in systems, skills, and knowledge? So I think this is a great question as well. This is really a systems issue, it seems like, but I think these things might be able to overcome by providing skills training within your department and collaborating with other departments on basic life support or ACLS, for example, as an example of a skill. In our setting, ACLS is required, or PEARLS is required, which is perioperative, the perioperative anesthesia-centered version of ACLS. But I agree that we need to set some standard, a minimum standard for our clinical workforce to deliver high quality care.
One comment that came to mind with that, is the ACLS and BLS is required of all bedside providers. That requirement is by the hospital, so it's not necessarily a requirement of your certification to be an anesthesiologist, for example, or to be a nurse, or to be a bedside provider. You cannot get credentialed at the hospital if you do not have that training. So that might be a suggestion for a way to influence your current system, is to make the hospitals demand that they have that. Then having said that, you have to come up with access to training and the fees for training, et cetera. So those things can certainly have a hefty cost associated with them. Sometimes you can get your employer, whether it's the hospital or group that you're employed with, to pay those fees. But it's an excellent question. But one I want to also qualify in that the care of critical illness should not rely on BLS and ACLS. Those really are the last step things to retrieve a patient from dying. The real care for critical conditions and critical illness is in preventing the cardiovascular collapse or respiratory collapse that happens in the first place. So real critical care prevents that from happening. ACLS and BLS can return spontaneous circulation, but the patient is still incredibly gravely and critically ill. So it's really not a solution for critical illness. It's a tool that we use to help get to a place of reversibility. Vanessa, do you want to read David's?
Yeah, this is David Moore. Thank you, Vanessa and Anna. Just to let you know, an international degree for nurses who are in refugee camps IDPs, conflict zones, is being developed to develop professional nursing staff in harsh conditions, and EECC is the logical model for this group and environment. That's fantastic. That is excellent. David, who is developing this? This is great.
I don't know if he's able to unmute.
Yeah, probably not. We'll have to email him. And then Lawrence Lee, what do you think of the idea of creating a simple clinical scale, call it CCCS, Clinical Critical Care Scale, similar to the GCS Glasgow Coma Scale or APGAR score, to try to more closely identify critically ill patients? I would collaborate in something like that.
I think that is a very good point, Lawrence Lee. It has been tried multiple times. If you recall, for sepsis, we were using QSOFA or SOFA scoring. The most recent 2021 updates to the management of sepsis and septic shock said that actually the QSOFA is not sensitive enough to detect all septic shock or sepsis patients. And so you can still use it, but it's not recommended as a screening tool. The early warning scores systems such as Muse or News, there's now News 2, are also scoring systems that have been developed. Muse and News come out of the UK. All of those can be used with a calculator. You can either hand calculate it, or there's several calculators that come as apps on your phone. And so those can certainly help people who are in hospital identify those patients that are at high risk of decompensation. I would encourage you to review all of those and see which one would work best for you. And that brings us back to what some of the EECC authors developed, which was the vital signs directed therapy. Because if you're in an acute situation and there's a critically ill patient in front of you, or someone you think might be critically ill, there may be some barriers with sitting there to do a calculation or to really understand what to do next. Whereas something like the vital signs directed therapy tells you this vital sign in isolation is abnormal. Here's what you do about it. If your blood pressure is too low, you give a little bit of IV fluids. If your oxygen is too low, you give some oxygen, and it tells you how much. But then it also directs the bedside provider to reassess. And this is what goes back to the comment that you, Lawrence Lee, made earlier. It's like continuous reassessment. So you might do something to help correct the vital sign, but then you need to reassess and reassess. And if it doesn't get better, then you need to escalate to the higher level of care. So vital signs directed therapy is a very simple protocol tool that not only identifies the critically ill, but gives that first step to the bedside provider. So even providers that may not have a lot of education and training will know what to do next. It also encourages reassessment and escalation to a higher level of care. Yep. In the studies that used the vital signs directed therapy and validated that, it actually improved mortality for the patients that were hypotensive, which is incredibly significant, right? Anything in our line of work that improves mortality, we tend to listen to. So check out Muse, check out News, check out News 2, and then I encourage you to look at the vital signs directed therapy protocol as well for use on the wards and PACUs.
Excellent. And then I think this will be our last comment, and then we have to switch this off. Malone Chaya, has anyone explored the opportunity to leverage internet-based solutions to provide expertise in resource-poor environments? We have the ability to do virtual consults already. Yes, I think that's it is being done. I am not sure who does it, but there is tele-ICU consults. We here in Minnesota, we have, for example, rural hospitals that are connected to us, where we have a 24/7 consult service to and actually an anesthesiology consult service to low resourced areas where we provide virtual consults. And I believe there are larger programs underway with institutions from higher resource countries that are connected to lower resourced settings. But I currently do not have a good example ready. Anna, do you have an example? I wonder if Vanderbilt is doing that.
So yeah, so I put a couple, typed a couple answers in there, but there are certainly programs, you have to look for them. There's not one program for everyone, unfortunately. Project Echo does a lot of this kind of virtual consultation services. There's multiple different programs. Sometimes it's diagnosis specific, such as consultation for diabetes management, for an example. So for critical care and ICU, there are tele-ICU programs out there that are more like kind of this mentor consultation service, but they're usually done at the institution level. I don't know of any off the top of my head that work at the level of like critical care societies or professional societies. However, I would keep my eye out for some of the anesthesia professional societies, such as the World Federation of Societies of Anesthesiologists. I would also keep my eye out for the Society of Critical Care Medicine, the European Society of Critical Care, and then the umbrella organization over all the critical care societies would be the World Federation of Intensive and Critical Care. So if something were to be developed or is in development, I would probably research those areas. And Vanessa, I know you said that's the last one, but you only have one question left.
Well,
So
I know. Let's do this one. Okay. What would be an effective way to keep general anesthesiologists working in low resource countries to maintain and or enhance critical care skills, as well as delivering care to severely ill patients, knowing that their services are not reimbursed or are poorly reimbursed?
this goes back to one of those frustrations that you have to turn into an opportunity, because there's a lot in that question, and some of the bottlenecks are going to be resources just to deliver effective, high quality critical care, workforce limitations, and that maybe you don't have enough providers at the bedside. And then additionally, reimbursement is always a problem, even in high income countries. We're always constantly fighting to get fair reimbursement for our services. And if you can make money somewhere else doing something else, and that's going to be better for you and your family, then surely that's going to be a pull out of the critical care practice. I think being a medical provider, whether it's nursing or physicians, I think we all have some sort of innate call to service, and we have to just ride that and nurture that as long as we can. Sometimes you take breaks from practice and come back because you might feel overwhelmed or burned out. But I think all of us have this passion for making the lives of other people better. I don't have a simple answer for this question. I'm just telling you what drives me. And I do feel like when you can serve your neighbors, your community, your global community, it really does give you a lot in return. And I think if you're in a leadership position or you have that draw towards advocacy, then it is our job to frame these issues and convince those that are higher up in leadership and governance of how important this is. The health quality commission put out by the Lancet that I referenced, where it said you'll know that your healthcare system has good quality healthcare when the leaders stop leaving the country to get medical care. So you can always frame things around when trying to convince others, framing the issue around patients, framing the issue like, what if it was your sister? What if it was your mother? What if it was your wife, your son, your husband? You know, if you frame things around the patients, it really is a convincing thing, and people start to look past the money, look past the logistics, and really get that shared passion for bringing high quality healthcare to everyone. It's a human right. That was
Thank you for that answer. It's a very difficult question
a hard
to
question.
answer.
Yeah, sorry.
There's no simple answer. There's no simple I don't know, pill to cure that. But thank you for all your great questions.
Yeah.
Thank you for listening in. Thank you, Dr. Anna. It's always fantastic to do these webinars with you. And have a good night, everybody.
Yeah, and thank you to IARS for allowing us to have this conversation. Anyway, hang in there, take good care of patients, and take good care of each other. Thank you.
Thank you. Bye-bye.